Welcome back. Week 3, this is PowerPoint number 2, and this we are focused on randomized clinical trials. So why not just do case reports? Why not just observational studies with a lot of subjects? Well, part of the reason is because of something that are called confounding variables. These are unstudied or unknown variables that interfere or influence the outcome. So an example of this would be there is an observed association between coffee drinking and pancreatic cancer. Can we say for sure that drinking coffee causes pancreatic cancer? Well, remember, association doesn't equal causation. So an association is an exposure possibly related to an outcome. So the thing is, some coffee drinkers smoke. Smoking is a known risk factor for pancreatic cancer. Therefore, we can't say definitively that drinking coffee causes pancreatic cancer. So let's talk a little bit about causal relationships. There are 3 conditions that must be present. The cause has to precede the effect. It's kind of a no-brainer. There must be an empirical or observed relationship between the cause and effect, and the relationship cannot be explained by any other factor. So let's look at some characteristics of randomized clinical trials. This is one of the best ways that we determine cause and effect. It's also sometimes called a randomized control trial. So what we're looking at is something that is always prospective. So why might that be? That's right, we're actually following, we're going to do an intervention and then we're going to follow a group, 2 groups of people generally. The researchers may need to intervene. This is performed in a very controlled setting because we're trying to minimize those confounding variables. And it's always done with a comparison or a control group. So we're going to try to minimize the confounding variables as much as possible. We're going to take a whole pool of people, ideally that are non-smokers, because we know that cigarette smoking can also cause pancreatic cancer. So we're going to make sure that all of the people that are in our group don't smoke. And we're going to have one group of people drink coffee, and we're going to have one group of people that don't drink coffee. And we're going to see if there are, if coffee actually causes pancreatic cancer, or maybe one of the contributing effects to pancreatic cancer. They're going to be followed over a short period of time, and they're going to be tested at random intervals. So when we've got a randomized clinical trial or randomized control trial, we have a group of eligible patients. They're being randomized. So what does that mean? Randomized means that they're going to be put into a couple of different groups, minimum 2. So we got one group that gets a treatment, and then we're looking at the outcome. The other group, the control group, doesn't get the treatment, and we're looking at the outcome. All right, so let's talk a little bit about randomization. So ideally, why are we doing this? It's to control variables. So we take the eligible subjects and we divide them into groups. Now the selection process can be a problem. I'll talk about that here in a moment. But what we're doing is we're looking at certain types of studies. We're looking at certain interventions. And one of the things that can be a problem is that study topics might cause issues. For instance, massage. Why is that? Well, how do you fake giving a massage? How do we know that maybe it's not just the dim lights and the soothing music and the comfy sheets and the person that's paying attention to you? How do we know that that's not what is actually helping people to relax, if that's in fact what we're looking at with massage? We are attempting in randomization to distribute people equally. So concealed allocation is something that we're used to prevent selection bias by concealing the allocation sequence from those assigning participants to intervention group until the moment of assignment. So basically what this means is that we're not letting people know which group that they're going to be in. Blinding is intended to prevent bias on the part of study personnel. Talk about that here in a moment. Blinding. So it's used to reduce bias on the part of research personnel. We've got single blind, double blind, and triple blind. So with a single blind study, the assessor doesn't know which group the person or the subject is in. When it's double blind, it means that the assessor and one other person, like the researcher or the subject, doesn't know which group that they're in. The triple blind means that the assessor, the researcher, and the subject don't know which group that the subject is in. The thing to remember about this is they're often computer generated and numbers are assigned to create anonymity so that people can be put into groups so that nobody really knows which group which person is in. Let's look at some of the strengths of randomized clinical trials. So we can help to establish cause and effect. That's a big one. So far, it's really the best that we got. We're trying to limit bias. If it's well done, if the study is well set up, it will limit bias. And the collection of data as the events occur. So again, this is prospective. We're creating two groups. We are treating them or not treating them, and then we're looking at the types of outcomes that may show up after a certain period of time. Limitations of randomized clinical trials is that sometimes it's really impossible or unethical to randomize. So again, this goes back to how do you put somebody in a fake massage group? It can lack generalizability due to controlled settings. The results can be averaged, which may not apply to individual patients. They may not find out what any kind of qualitative information, so we may just get numbers, right? That's usually what happens with our randomized clinical trials. It can be expensive and time consuming. You may have a lot of people that are involved in the entire process, and it may not yield results that the researchers were hoping for. So this kind of goes back to some of the stuff that we talked about in week 1. Is that, you know what, it might be a successful study, but it didn't yield the results that the researcher was really looking for. So randomized clinical trials for massage therapy. This is one of the reasons why, or a couple of the reasons why it can be very difficult to do studies for massage. There is difficulty with controlling for the confounding variables. So again, proximity. So how close a person is, the massage therapist or the practitioner is to the person that's getting worked on. How do you fake a massage? It might be the devoted attention. So somebody paying specific attention to you, the therapist paying particular attention to the subject. The setting, again, like I mentioned, it could be the table, it could be the lights, it could be the music. You know, there's similar issues with this with other modalities that fall under complementary and alternative medicine. So despite these limitations, randomized clinical trials are the best that we have to determine effectiveness of a given treatment. Now, this isn't to say that we can't do studies on massage therapy. It just makes it a little bit more difficult. Some terms and some concepts for you to know, again, for your final exam. Know about randomization. Ideally, this is used to decrease variables and bias. The concealed allocation, something being prospective, helping to show association or causation. These are the things also that are strengths in randomized clinical trials. There's blinding. I want you to know about some of the characteristics of randomized clinical trials, that there's usually a minimum of 2 groups, a treatment group and a control group, and also to know some of the strengths and limitations of research randomized control trials, knowing them specifically. All right, weekly graded activity. Don't forget, there's 2 parts.